Okay, I think we can get started. I see quorum here. I see some old familiar names as well as some new names. So thank you everyone for joining us. I'd like to welcome everyone to this CanCare VJC. I think this is our 15th session, and we're very excited to have the lead investigator of the TTM2 trial, Dr. Nielsen, joining us from Sweden, which I believe is late at night for you. So thank you for joining us in this virtual format.
Thank you for inviting.
Thank you. Well, let's get started. So Kyle Fiorini, who's a critical care medicine fellow at the University of Western Ontario in London, Ontario, will be presenting the study, and then we'll hopefully have a spirited discussion that follows. So go ahead, Kyle. Want to share your screen?
Sure. Thank you so much, Dr. Goldfarb. I am very excited to present the normothermia or hypothermia versus normothermia after out-of-hospital cardiac arrest TTM2 trial, especially in the presence of the primary investigator, Dr. Nielsen. So thank you so much for the opportunity. Going right into it, targeted temperature management has been a strong recommendation in a number of guidelines and practiced in the majority of intensive care and coronary care units throughout the world. But despite how often it's used, the evidence, as we know, is quite mixed and uncertain on not only what target to use or even its benefits. And looking briefly at the background of the largest studies for TTM, the OHCA trial was in 2002 in VF arrest patients with a target of 32 to 34, showing favorable neurologic outcomes and reduced mortality with that. And then TTM1, Dr. Nielsen, first author there, was the 33 versus 36 degrees after cardiac arrest. And this kind of put a lot more doubt into the practice of targeted temperature management, as there was no conferred benefit. And there was a lot of question stemming from this, whether this is absence of fever that derives the true benefit versus hypothermia itself. And further convoluting the question is the Hyperion trial from, I think, 2 years ago now, where patients who had non-shockable rhythms for out-of-hospital cardiac arrest did have favorable neurologic outcomes with a targeted temperature of 33 versus normothermia, which led to the TTM2 trial, which the objective was to assess the beneficial and harmful effects of hypothermia as compared to normothermia with early treatment of fever in patients after cardiac arrest. So this was a open label RCT with blinded assessment of outcomes. It included adults with coma following out of hospital cardiac arrest to presumed cardiac or unknown cause. And the investigation group was targeted hypothermia 33 degrees followed by controlled rewarming versus targeted normothermia with early treatment of fever, which they defined as 37.8 degrees or greater. Primary outcome was death from any cause at 6 months. The main secondary outcome was functional outcome at 6 months, as assessed by the modified Rankin scale. And they compared the adverse events in both arms of pneumonia, sepsis, bleeding, arrhythmia resulting in hemodynamic compromise, and skin complications due to the temperature management devices. They included all patients that were 18 years of age or older who had an out-of-hospital cardiac arrest, presumed cardiac or unknown. They had to be unconscious and unable to obey verbal commands and no verbal response to pain post-arrest, and it had to be 20 minutes of consecutive return to spontaneous circulation. They excluded those that they couldn't reach with screening within 180 minutes of their ROSC time, anyone who was unwitnessed cardiac arrest with asystole as the initial rhythm, and limitation and goals of care. They enrolled 1,900 patients, 37 did not obtain consent or withdrew consent, 2 were randomized twice, leaving 1,861, 930 in the hypothermia, 931 in the normothermia. A very small amount of the patients' outcome data was unfortunately missing, leaving 925 in both arms. The groups were very well balanced by randomization. The demographics, medical history, characteristics of the arrest, first rhythm were all relatively equal in numbers. It was 75% roughly being shockable rhythm. And the clinical characteristics on admission were also well balanced. The protocol they used for TTM was in the hypothermia group. They used immediate cooling to reach a target of 33 degrees Celsius, and they maintained that target until 28 hours after randomization, where they rewarmed patients to 37 degrees at 1/3 of a degree per hour. The normothermia group, they aim to maintain a temperature of 37.5 degrees Celsius or less. If conservative measures were insufficient to maintain that target and temperature reached 37.8 degrees or greater, then active cooling was initiated to reach a target of 37.5. This is the graph of the two arms showing the difference between the two groups and how well controlled the normothermia group was. You can see there's quite a difference between the two. The TTM protocol, the median time was quite quick at 34 degrees Celsius to 3 hours to reach a 34 degrees Celsius. 6% unfortunately had to be rewarmed early, primarily due to cardiovascular instability and arrhythmias. And in the hypothermia group, 95% received active cooling, the remainder having contraindications. And in the normothermia group, 46% received active cooling to reach the 37.5 degree target. Prognostication and early withdrawal of life-sustaining therapy was allowed per the study protocol, and an independent physician at 96 hours after randomization or later, who's blinded to which group the patient was in, performed a neurologic assessment. If the assessment showed a poor prognosis, withdrawal of life-sustaining therapies was allowed per the study protocol, and that decision was made by the treating physician. The primary result was survival at 6 months. Here was the graph of the survival curve showing they're quite narrow and not much difference between the two. And in a numerical format, you can see that the confidence interval passes 1 for all patients in mortality. So there was no difference between the two groups. And in the pre-specified subgroups, including non-shockable and shockable rhythms, there was no difference between the two groups. In the secondary outcomes, the modified Rankin score was the main secondary outcome at 6 months. And again, the confidence interval passed 1, no difference between the hypothermia and normothermia group, nor in the pre-specified subgroups. Other secondary outcomes that were looked at in the paper were the health-related quality of life, which they used the EQ5D5L scoring system, which showed no difference between the two groups. And the number of days the patient was alive and out of hospital, there was no difference between the two there either. Adverse events were equal between the two groups, except for in arrhythmias resulting in hemodynamic compromise, which was statistically higher in the hypothermia group. So in conclusion, in patients with coma after an out-of-hospital cardiac arrest, targeted hypothermia did not lead to a lower incidence of death at 6 months compared to targeted normothermia. Secondary outcome data suggested that hypothermia does not improve neurological outcomes as assessed by the modified Rankin scale, and adverse event data suggests that hypothermia may lead to more arrhythmia and hemodynamic compromise. So with that, I turn the discussion to everyone here and Dr. Nielsen. Thank you so much for the opportunity.
All right, let's open up the floor. I have some questions, but I'd like to hear from our esteemed audience. Does anyone want to get it started? You can do it in the chat group or out loud. Okay, I can get it started. One of the things I think may be a harmful message from this study is that strict enforcement of the temperature control doesn't matter. So we actually see in the normothermia group here, there's a strict enforcement of the normothermia, right? So I think Kyle pointed out that about 46% of patients actually had active cooling in the normothermia group. So I think that's something that the message I think might get lost in someone who just quickly scans this paper. I want to know maybe some of your insights on that.
Do you want me to answer that question? Yeah.
Yes, please. Yeah.
Yeah. No, it was definitely so as you describe it, and it was really a lot influenced by the TTM1 trial, where we had very strict temperature control also in the 36 arm. And we had this threshold where we defined fever, 37.8 and above. And since we had also strict instructions to all the sites to record the temperature immediately from admission to ICU. Also in the normothermia group, we had this continues. So as soon as the patient started to reach what was defined as fever, temperature management systems were turned on. Some sites already had pads on since they didn't want to go to a level above, maybe lose 30 minutes, 1 minute, 1 hour to put on the pads or put in an intravascular catheter. So that was strict, and I think it was what we estimated that it would be half of the patients approximately that would need some kind of device. From an academic perspective, though, I think it would have been even better from a trial perspective to have include also a control group with no temperature management at all. But that might be an outstanding question still after this trial.
We have a question from our chat group. How does one explain the benefit in the positive trials? Absence of fever would be the rationale. So
you mean the positive trials, the HACA trial,
yeah.
and yeah, I think if we have to be honest, the numbers needed to treat for both the HACA and Bernard trial, they are very optimistic, I would say. There are very few interventions in medicine that has that type of extreme effect. So I think that a lot of the effect we see there might be due to other factors than an effect of temperature management. We have to realize it's more than 20 years ago that these trials were performed. It was a totally different way of performing randomized trials. All the strict regulations according to consort, they weren't in place. So I think it might be a bit of bias there. And I also think that the sample size in those trials are quite limited. So I think we also look at random error. I must say that's my personal belief that that's the biggest difference between these trials. And then we have the Hyperion trial, which is a more modern trial, but it's also interesting to see that for mortality, it's actually exactly the same results as in the TTM2 trial. It's the signal on neurological outcome, but it's based on very, very few events. A little bit more than 30 patients altogether that is evaluated. So I think that might be a signal, but it's not anything that I would define my my practice on. And we've been discussing to do a meta-analysis of the non-shockable groups from TTM2 and from the Hyperion, and I guess that everyone could guess the results from that already without having done the analysis.
We go to the next question. Thank you. Do you think this data would apply to the eCPR patient population? Because I know they've been excluded a lot from these previous trials.
Yeah, they were excluded also here. So I think I think the word is still out there. The jury is still out for that group. I know that sites in, for instance, Czech Republic, who were part of the TTM2 trial and also performed eCPR randomized trials that were presented at the American College of Cardiology this spring. They think that they will go for normothermia also for eCPR, but I think that is something that has to be studied further.
Okay. Great, thank you. So one of the questions we had is, do you think the guideline recommendations for TTM temperature will change based on this study? And I'll kind of ask you further, do you think this is the definitive study to answer this question? Or is there more, and you mentioned eCPR may need more data, but are there any other subgroups we should look at? Or do you think this is kind of definitive? These are the new guideline, going to be the new guideline recommendations based on the results of this study?
I definitely think that guidelines will be influenced by the trial, but I'm not part of the group, so I don't know what they will come up with. But I don't think that this is the definitive trial. I think that every trial always gives you new questions to answer. So it's a process that's just ongoing. And I would go in two directions with a new trial. I think the TTM concept that we've been performing for 20 years, I do not think it's likely that this has an effect. I don't think we have done anything with the temperature management down to 33 degrees during these years. But I think we have to look at the very, very early phase. I think that there are signals in those pre-hospital cooling trials where they start during ischemia or immediately after ischemia. But these trials have so far been underpowered and too small. I think if you want to look and invest resources into targeted temperature management, you should look at that end of the spectrum. Having said that, I would also look at the other end, and I'm not sure that the fever management with TTM devices that we've been advocating after both TTM1 and I've seen in the blog post and Twitter debates after TTM2, I'm not sure that has an effect either. I mean, we hear people say that fever is detrimental, but there are no data so far that tells us that this is the case. It might be the opposite, or it might be totally neutral. So I think we should study that as well. Is the continued fever management with TTM beneficial, or is it neutral, or is it even harmful?
Can I just ask you, what was your hypothesis before the study? Did you believe that the therapeutic hypothermia was not a good strategy? Was you coming in thinking that strict normothermia was equivalent to this targeted hypothermia? That was your approach? Seems like that's the way you're talking.
I've been part of this since 2002. We cooled the first patient in my hospital in Sweden in May 2002. So I've been really part of this, and I've been in the lab seeing the mice and rat models, and I really always had a belief that it could work. But then after we had started the clinical implementation, we also collected registry data, and when we dissected that registry data, quite a lot of patients' data, we could not really see any dose effect or any timing effect or anything. It was very neutral in that registry, the hypothermia registry. And with that, we wanted to see if we could tailor the therapy to a better intervention than what was proposed. And we started to discuss a new trial back in 2009, 2010. And when we started to think, what trial should we do next? Is it a duration trial, or what is it? We got the advice from serious methodologists, trialists, some from McMaster in Canada, to go back, look at the evidence, assess the evidence, and start from the beginning. And that's how it all started. I had a hope for the TTM1 trial that 33 should be the better one, and I also did that this time, and that was why we chose 33 and not 36 as the intervention arm in TTM2. We really wanted to give TTM the best possible chance to show a benefit.
Thank you for that answer. One of the things we mentioned quickly before this journal club started, you mentioned briefly about the practice in your center. And I think there's a question from the audience that's very interested. The home of TTM2, what do you practice at your center? Has it changed from the study, or was it you've been practicing this way before? Is strict normothermia your standard practice? And if you do cool them, how fast do you cool them with cooling devices? Do you aim for like cooling them within 1 to 2 hours to hypothermia, or you've kind of abandoned that practice?
No, practice today after TTM2 is to perform the TTM2 normothermia arm. We think that gives us room for concentrating on the patient in every other aspect. Cardiac care, coronary interventions, hemodynamic stabilization. We hook up the neuromonitors with the continuous EEG, and we start the standard care, and then we continue to just record temperature, and if the patient develops fever, we treat that. But we do not start TTM immediately in the majority of patients unless they have a fever. And we do not cool to any sub-level temperatures anymore. But the group at the hospital and the surrounding hospitals in the Lund University group, they are very used to randomized trials now, so we don't really think of what temperature we use. We just use the temperature that's either in the protocol or in the randomization decision.
Thank you. And if you're looking for sites to keep people cool in the future, if you decide to go that way, it was very cold in Canada at times, so we'd be very happy to include to be part of one of your future studies. Do we have any questions from the audience before I go on to my next question?
I wouldn't mind asking a question.
Yeah.
Nicholas, I'm wondering in your presentations if you are reinforcing the need for continued guideline-directed neuroprognostication. As I'm sure you're aware, a lot of the registries showed large interhospital variability in withdrawal times and application of neuroprognostication. And one of the thoughts was keeping people cold and rewarming was allowing people longer times for neuroprognostication, and people weren't withdrawing too quickly. What are you emphasizing in this new era of perhaps fever prevention rather than hypothermia?
I really think that it's a very good point to discuss, but I really think you should separate these questions because it's two different things. And I cannot see why you cannot perform strict temperature control according to the normothermia dogma or whatever until we know more how to do that, and at the same time prolong your observation time up to 4 or 5 days and perform the prognostication at that and collect information during that time. I think that's something you definitely should do, and I think that might be one of the big benefits of the concentration of the cardiac arrest group that we've seen. Much thanks to the TTM and hypothermia protocols. There's been a lot of focus on the cardiac arrest patient. So I definitely think that we should continue to develop strict prognostication guidelines and protocols. But I also think that we should look into sedation practice. It might be that normothermia protocol opens up for earlier desedation, or maybe not using sedation at all for those unconscious, and maybe start sedation when we need sedation rather than the opposite. But we should definitely study this in randomized controlled studies before we do that. But I think that might be an opening. So we might be able to wake up patients earlier than we do today, or they may regain consciousness spontaneously. But I think that the neurologic prognostication guidelines will be strengthened by the results from the TTM2 trial. We have lots and lots of data to present the next couple of years.
Any other burning questions from the audience? To challenge the audience, if there's no questions, is anyone in the audience would practice differently than the control arm of this trial? Does anyone think that we should still be cooling patients, or not convinced that we have enough data to make the definitive decision? I guess silence is consent.
It's a little bit interesting to see that many polls that's been out on Twitter, they say that 36 is still the most popular temperature to choose. I wonder why that is.
Yeah. Dr. Schnell, were you about to say something?
Oh yeah. Hi, Nicholas. Good to see you again virtually. Wish we could share a beer.
Yeah, definitely.
Thanks again for all your hard work, and sorry for not being able to help you out as a enrolling site. It's a fantastic trial, obviously, and I think it will really change management. Here's a practical question, Nicholas. Just does this mean really that we should move away from intravascular cooling and move towards surface cooling devices? It seems that there's very little reason to use an intravascular device anymore. In a surface cooling device, you can use longer, less need for invasive line. So that's kind of more of a practical question.
Yeah, I haven't really been thinking very deeply on this issue. We haven't analyzed if there are any differences between the two. We have, as you may have seen, about approximately 1/3 of patients had intravascular device. But there are still the question about shivering that I think is interesting. That I think that surface cooling systems might induce more shivering than the intravascular catheters. But if you just go for normothermia, it might be a little bit too invasive to put in a very, very thick and intravascular device that might cause problems. So I don't think I can give a recommendation right now. We have to look into our data. We have quite a lot of it, and we're analyzing it at the moment. So I hope that we can give better answer within a few months, maybe this autumn or something like that.
Just so I want to ask a question. Am I correct in reading that there was two kind of results or manuscripts written for the answers, where the assessors were blinded to the results of which group was assigned? Is that correct?
Yeah, that's correct. We blinded as much as possible, since we could not blind the intervention at the bedside. That was impossible. But we blinded everything else, and we blinded the assessment and the neurological prognostication. But we also blinded the full statistical analysis process. So we separated temperature data from the rest of the data, and we also blinded some of the physiological variables that could, like bradycardia, stuff like that, it could tell the reader which group was which. So we tried to balance this throughout the analysis process. We also had two separate statisticians that performed the analysis, and we compared them in the end. And then when we had the results, we only had the results with group Y and group X. So then all the authors had to think twice, first with X being 33 and then X being normothermia. And we wrote two versions of the manuscript, the full manuscript. Every word was written twice. And when that was done, we opened the envelope with the randomization code. And I think that is something that should be done in every randomized trial, because it's so easy to use your imagination or unconscious bias or conscious bias and introduce words that lean in one way or the other. And if you do like this, we had in the author group, it was 61 authors. We had those with a bias towards 33. We had those with a bias towards normothermia. I knew that from start. And we had those neutral in the middle. But everyone had to align and be very, very neutral and balanced in their wording, and everyone had to agree on that.
I think you set the bar very high, but in a good way.
Yeah, I mean, it should be a demand. Yeah. I think it should be demanded. I think that's the part of the analysis process that's the most dangerous when people start to write.
Yeah, well, I greatly appreciate your thought. Is there any burning last questions before we go? I greatly appreciate your time. I'm sure our audience here learned a lot. Everyone stuck around to the end, which is not always, but I greatly appreciate your insight. And I think this is a landmark trial, and I'm sure we're going to be discussing it for years to come. Thank you so much for joining us.
If you have any other questions, just email me and I try to answer them. So that's the email address is in the publication.
Great to see you. Thank you so much.
Yeah, thank you for having me.